Good day, everyone. It's time to start our ASPA Flex webinar. Today is the first webinar of the Pediatric Sedation SIG. We have a few very renowned pediatric anesthetists with passion in pediatric sedation to deliver our talks today. And these are the foundation lectures of our SIG training and discussion for the subsequent time. So we want to introduce briefly to our pediatric sedation special interest group. This is SIG to promote safe and effective pediatric sedation in your practice for any practitioner who will look after children. And the group will serve as a platform for healthcare professions to share knowledge, best practices, research findings related to pediatric sedation. Serpil Austen is our current ASPA president, and she's the key person to push the development of this SIG. And she is the associate professor in a teaching university in Istanbul. She's also a member of many important anesthesia society and council, as you can see a list here. And she has lots of skills and interests in anesthesia, but in particular, she is a pediatric anesthetist with interest in pediatric sedation. Serpil, I hand over to you.
Hi, everybody. Vivian is working in the Department of Anesthesiology and Perioperative Medicine in Hong Kong Children's Hospital. And she is the honorary clinical associate professor at University of Hong Kong. And she is the lead of the sedation SIG in ASPA. And she has many studies in pediatric anesthesia and sedation. She is also interested in use of TCI in children, and she has lots of skills in pediatric anesthesia as well. Vivian, over to you.
Right. Thank you, Serpil. So these are the objective of our special interest group. We want to provide a forum on the internet for anesthesiologists and pediatric sedation provider to share knowledge and experience related to pediatric sedation. And we want to promote safe and effective pediatric sedation practice across various medical specialty. Hopefully we can give advice on the best practice for pediatric sedation. They are evidence-based. We will have a series of different module on pediatric sedation, and the activity is going to be happening on Canvas, which is platform for ongoing interaction on education. So on this platform, we will use it for our ongoing discussion, experience sharing, etc., or resources sharing. So this is totally new, and we want to explore and use this platform. Hopefully we can get together and learn from each other and improve our service to our children. And this is our tentative schedule for our activities on Canvas. So today's lecture will be revisit on Canvas, and today is the launch of this activity. We have our webinar, but we will revisit the lectures one by one, and each one will have a period of about 8 weeks. And after that, we will have a workshop in the next ASPA meeting in Nepal. So this will be our first sedation workshop by the SIG. And if you want to join us on Canvas for this ongoing activity, please do a screenshot, then become a member of ASPA, create a Canvas account, as well as join this discussion platform by joining the ASPA Pediatric Sedation SIG. So this is today's program. We will have Professor Charles Cote to talk on the history and role of pediatric sedation. We will have Dr. Kira Mason to talk on safe pediatric sedation. And then we will have Tracy Tan from KK Women's and Children's Hospital, as well as Vancy Court from the Hong Kong Children's Hospital to talk on the future of pediatric sedation, what lies ahead. Some housekeeping for today's webinar. If you have any comment, any questions, any suggestion, please do it on the Q&A. The chat and raise hand functions are disabled. Moderator will highlight your question to the appropriate speaker. We will have a short period of question and answer session after each talk. And some question, if it's simple enough, may be answered by text in the Q&A box. So stay tuned. And we may have some polling. When the poll is launched, you have some about 30 seconds to respond and submit your answer, and we will share the results soon after the poll is end. And this information presented from this webinar is intended for education purpose only and is not meant to be a substitute for professional medical advice, diagnosis, or treatment. And the views expressed in this presentation are those of the presenter and do not necessarily reflect the opinion or policies of any institution or organization which they are affiliated. Additionally, the information presented may not be applicable to all individuals or situations. And if you want to get your certificate of attendance, please respond to the post-webinar survey, which will be emailed to you tomorrow. And then if you have your full name and email address filled in, we will send you the certificate after. Please share and like us on Facebook, YouTube, and on our website. So Serpil will introduce our first speaker.
Thank you, Vivian. I have the honor of introducing Professor Charles Cote, who is an Professor Emeritus in Anesthesia at Harvard Medical School. And he's a retired professor, although he's always very helpful, attending all the pediatric anesthesia meetings. He's a distinguished professor emeritus and from Massachusetts General Hospital for Children. He's renowned for his expertise and contributions to pediatric anesthesia and has built a illustrious career dedicated to advancing the field and improving patient outcome. He has interest in pediatric anesthesia and patient safety issues, sedation guidelines. He has set these guidelines, monitoring in pediatric anesthesia and pediatric pharmacology, and also drug approval process of drugs for use in children. And he has lots of clinical research. And also he is interested in woodworking and furniture making as a hobby. And please, Charles Cote, over to you.
Good morning. What I'm going to talk about today is the history and role of pediatric sedation. My name is Charlie Cote. I'm a retired professor of anesthesia at Harvard Medical School at the Massachusetts General Hospital in Boston, Massachusetts. I have no financial disclosures or conflicts of interest. So the very first guideline by any organization was published in 1985. And we called it the Guidelines for the Elective Use of Conscious Sedation, Deep Sedation, and General Anesthesia. And we rue the day that we use the phrase general anesthesia or conscious sedation in the title because these were confusing to everybody. The guideline was developed in response to 3 pediatric deaths that had occurred in California in a single year. And the AAP leadership had asked our section on anesthesiology to come up with some guidance. 6 years later, we revised the guideline and changed its name to emphasize what we really intended, which was the Guidelines for Monitoring and Management of Pediatric Patients During and After Sedation for Diagnostic and Therapeutic Procedures. And then this guideline was updated in 2002, 2006, 2016, and 2019. And we'll go over some of the stages that occurred during this time. So the role of the guideline, any guideline, is to emphasize safe practice, to provide a roadmap to safety. So in this case, informed consent, appropriate fasting before sedation, appropriate monitoring, including pulse oximetry, a time-based record to record what happened, age and size appropriate equipment, pre-sedation evaluation, an appropriately staffed and equipped recovery facility, strict discharge criteria, and no out-of-facility prescriptions. And you'll see why these things all became part of the guideline in a few minutes. Now, the other thing that was important was to unify the sedation terminology amongst the many organizations that have provided guidance here. And so the AAP, the American Academy of Pediatrics, the American Society of Anesthesiologists, the American Academy of Pediatric Dentistry, and others, we now use the phrase minimal to be corresponding to what used to be called anxiolysis, and moderate for what used to be called conscious sedation or sedation analgesia. And the key here is that the patient remains interactive. And then, of course, deep sedation remains the same. And this is where the patient responds only to repeated stimulation. And this does not mean reflex withdrawal to a painful stimulus. So the concept of rescue was exceedingly important. And that's the roadmap for this guideline. So what does rescue mean? If a patient's intended level of sedation is minimal, you must be able to rescue from a state of moderate sedation. If your intended level of sedation is moderate, you must be able to rescue that child from a state of deep sedation. If your intended level is deep sedation, then you must be able to rescue that child from a state of general anesthesia. And what does rescue mean? It means airway, 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 airway until proven otherwise in the vast majority of pediatric patients. So the changes that we made in 2006 were part of this process. In 2006, the Academy of Pediatrics and the American Academy of Pediatric Dentistry now had the same document, virtually the same document. We recognized that dietary precautions were inadequate in terms of making specific recommendations for emergency patients. So those patients in the emergency room that need to have something performed, it's difficult to make strict recommendations about fasting. We warned about nutraceuticals and drug interactions on the cytochrome system. And now in 2006, we made training and maintenance of advanced pediatric airway skills required. We then also recognize that children less than 6 years of age are usually going to require deep sedation. And we encourage continuous quality improvement, the use of capnography, familiarity with airway adjuncts such as the laryngeal mask airway, and patient simulation training. So these were all encouraged in 2006. And we warned about nutraceuticals and checking for drug interactions. So it turns out in the US about 30% of children are taking some form of nutraceutical, and 70% of the time the parents will not tell us that the child is taking one of these adjuncts unless we ask them. So you have to ask. And of course the ones we worry about are the G herbals, garlic, ginkgo, and ginger that are associated with increased propensity towards bleeding, and St. John's wort, which might alter the cytochrome P450 system. We also added the acronym SOAP-ME. S is for suction, working suction. O is for oxygen and an adequate supply of oxygen. A is age and size appropriate airway management equipment to manage a non-breathing child. P is for pharmacy for all drugs needed to support life and reversal agents. M for monitors, including pulse oximetry and size appropriate probes, EKG, blood pressure, capnography as appropriate. And then E, special equipment like a defibrillator or infusion pumps. Now let's circle back to the initial early guideline development. What data were used to support this in the first place? So this goes back to studies that I did looking at critical incident analysis. What went wrong? Why did it go wrong? How could we prevent that adverse event from occurring again? And we used a variety of sources to gain insight onto these events. So the Food and Drug Administration Adverse Drug Reporting System, 629. United States Pharmacopoeia provided about 15. We sent out a survey to pediatric anesthesiologists, pediatric intensivists, and pediatric emergency medicine physicians who were members of the American Academy of Pediatrics. And then people started sending me these things anonymously in the mail. And what outcome measures were used? Well, pretty crude: death, neurologic injury, prolonged hospitalization, or no harm. And again, these papers were published in Pediatrics in 2000. So all cases were reviewed individually and then debated in person by 4 people. And we used kappa analysis to see how much we agreed with the 18 possible different things that we had listed as possibly going wrong. And we have to thank Roche Pharmaceuticals for supporting this meeting. So there were 2 pediatric anesthesiologists, 1 emergency medicine physician, and 1 critical care physician. And then Richard Konis, who was the statistician for the ASA, did our statistical analysis for us for free. So the source of the final data set were 15 cases from the FDA, 3 from the United States Pharmacopoeia, 27 from the survey that we sent out, 8 that were sent to us anonymously, for a total of 95 cases in the final cohort. Now here's just 2 anecdotes that make you understand why this whole process was so troubling. The pharmacy dispensed the prescription in tablespoons rather than teaspoons, and at twice the concentration. And so this was chloral hydrate that resulted in a 3-fold overdose, and this child died. So that's a prescription transcription error. The drug was given at home by a parent. Oral midazolam, 0.5 milligrams per kilogram, a modest dose, and this child died. So this child was coming to a dental office, wintertime, in a snowsuit, put in a car seat. And all of you that have children out there, you know as soon as you put a child in a car seat and you start driving, they fall asleep. I don't know why that is, but they do. And then their head flops forward. And under normal circumstances, they can unobstruct their airway. But when they've received a sedating medication, they may not be able to unobstruct their airway. And that's what happened to this particular baby. When they brought the child into the office and opened up the snowsuit, the child was dead. Okay, so presenting events. As we mentioned, airway, 80% of the cases presented with some kind of respiratory compromise as the first event, and then 30 more progressed to a cardiac event as the secondary event. So that means inadequate rescue from the respiratory event resulting in a cardiac arrest. And what were the causes? Well, drug interaction was the most common cause at 44, drug overdose next, inadequate monitoring, inadequate CPR skills, inadequate evaluation prior to sedation, premature discharge from medical supervision, and inadequate personnel providing the sedation. What about drug categories? Well, opioids, benzodiazepines, barbiturates, and sedatives were all equally represented in terms of causation, 13 cases of chloral hydrate, and even 1 ketamine death. And this patient actually received several other sedating medications, so it wasn't just the ketamine sedation. What about the number of sedating medications? Well, this varied from half the cases getting a single sedating medication to as many as 5 sedating medications. So quite a variety of practices and drug combinations. What about route of administration? Well, again, a variety of routes of administration: IV, oral, rectal, nasal, intramuscular, and inhalation, usually nitrous oxide combined with something else. So all different routes of administration were associated with adverse outcome. So you can't say that one route is more safe than another. Where did the event take place? Well, 41 were documented as having occurred in a hospital environment, 22 in a non-hospital environment, primarily in dental offices, 8 at home after they were discharged from medical supervision, 4 in the automobile, and 2 of these were on the way to the dental facility, and 2 after they were discharged from medical supervision. So what was the outcome? Of those 95 cases, 60 had death or neurologic injury as the outcome, and half of those, 29, involved dental procedures. So the primary event, as we mentioned, was compromised respirations in the majority of cases. So what did we conclude? We concluded that the drug effects are the same regardless of what drug class, opioids, sedatives, benzodiazepines, route of administration, IM, oral, intravenous, who gives them, where the drugs are given, and you must have the skills to rescue the child who's suffered an adverse event as a result of over-sedation. So in 2016, we updated the guideline to now include capnography, interestingly, at the request of the American Academy of Pediatric Dentistry. I'm not quite sure why they asked us to update it to include capnography. My suspicion is that they had some adverse events that could have been diagnosed by capnography and resulting in a bad outcome. At any rate, with this 2016 revision, deep sedation was now required capnography, and capnography was encouraged for moderate sedation. So now AAP, an American Academy of Pediatric Dentistry, was very clear on what was needed for a child who is sedated. There must be one person whose only responsibility is to constantly observe the patient's vital signs, airway patency, and adequacy of ventilation. They must be trained in pediatric advanced life support and capable of assisting with any emergency event. And this is important, this "and" phrase right here. So that person who's responsible for observing the patient must be trained and capable in PALS, pediatric advanced life support, skills to rescue a child from apnea, laryngospasm, or airway obstruction, able to provide CPAP, able to insert supraglottic devices like a oral airway, nasal trumpet, or laryngeal mask airway, able to perform bag mask ventilation, able to intubate, able to perform CPR. These are all the skills you and I have, but the skills now by somebody who's supervising the deep sedation. So we have a problem in the United States with oral surgery because just as those deaths I described occurring in the dental office way back in 1985, pediatric and adult deaths continue to occur in the dental office with patients sedated, deeply sedated, or having general anesthesia. And the problem is something called the single provider model. So what is the single provider oral surgery practice model? It means the operating dentist performs the dental procedure and simultaneously also provides the anesthesia or deep sedation. There is no dedicated anesthesia provider present, and then they bill for both procedures. So they bill for the sedation and they bill for the dental procedure. So how do the oral surgeons justify this? Well, they have developed something called the Dental Anesthesia Assistant National Certification Examination, DANCE. And these individuals have just 36 hours of internet training, nothing else, and no educational requirements beyond high school. And after just this internet training, this person is supposed to be able to substitute for the independent observer recommended by the Academy of Pediatrics and substitute for all those skills that were described in the AAP guideline in 2016. Clearly, a DANCE certified individual is not capable of being a second pair of skilled hands as required by the 2016 version of our guideline. And it's because these DANCE assistants lack this medical knowledge, experience, or skills to assist with any kind of life-threatening medical emergency. So new directions occurred in response to the oral surgeon's DANCE program. We revised the 2016 guideline in 2019 to address the dangers of this single provider model using DANCE assistance. Now the AAPD guideline specifically states that for dental procedures, deep sedation or anesthesia must be provided by an anesthesiologist, a certified registered nurse anesthetist, a second oral surgeon, or a dentist anesthesiologist, and this is the "and" I talked about earlier, and the operating dentist or oral surgeon must be pediatric advanced life support certified. So now in office setting, you've got two people who should have the skills to rescue a patient who's been over-sedated or develops airway obstruction, laryngospasm, etc. We also got a joint statement on pediatric dental sedation published regarding our concerns of the use of deep sedation or general anesthesia for pediatric dental procedures with this single provider model. And this was jointly published by the American Society of Anesthesiologists, the Society for Pediatric Anesthesia, the American Society of Dentist Anesthesiologists, and the Society for Pediatric Sedation, published in August of 2019. And the most important statement was that the model that the AAOMS, the oral surgeons, continues to embrace does not ensure an appropriately qualified dedicated monitor, meaning the independent observer, who is prepared to meaningfully help in the event of a patient emergency. This was huge to get this thing published. Unfortunately, in the United States, this is a state-by-state battle. We have 50 states, so that's a lot of battles. In the United States, most dental boards will not allow any physician input into their guidelines or regulations. The dental associations have much more money than the physician organizations in terms of lobbying politicians. And I wonder if this is a problem that's common in your part of the world. Unfortunately, these dental accidents continue to occur in the United States. It's not limited to pediatrics. So here's a toddler who died after a dental procedure and was hooked up to an empty oxygen tank. And then the staff shut off the oximeter alarm because it kept going off, instead of figuring out, well, maybe it was going off because there was a real problem. And then, of course, we have this tragic death of a 53-year-old ASA1 cardiologist following sedation for a single dental tooth implant, one tooth. So these things continue to happen. It's not the drugs, it's not the venue, it's the people administering the drugs not being properly trained and prepared to deal with the unexpected. It is up to us as anesthesiologists to educate and train non-anesthesia providers how to administer sedation safely using the medical model rather than the oral surgery single provider model. So is this single provider model practice allowed in your part of the world? With that, I am finished. I hope you've enjoyed this presentation. I will be happy to participate in question and answer period pending the time available. And thank you very much. Have a wonderful day.
I thank you, Professor Cote, for your very valuable talk. We have a poll question based on Professor Cote's question. Is this single provider practice allowed in your part of the world?
Good morning, Vivian.
Good morning, Professor Cote. So let me
I think
share.
I think I messed up the time by 30 minutes, but but I'm here.
Oh, so no, we are so glad you joined. It's very early for you in your country. So then, regarding your question, about 1/3 of the participants say this is allowed, single provider sedation practice is allowed in the institute. Maybe, do you want to comment on this?
Actually, I'm glad it's only 1/3, to be honest with you, because in the United States, this is allowed. In every state in the United States allows this kind of practice. So throughout the United States, this practice is allowed. And part of the reason is that the oral surgery practice does not fall under the purview of anesthesia providers. So we have no input into their guidelines or their practice model. They don't even want us to talk to their leadership about this kind of stuff. So I'm glad to hear that at least 2/3 don't allow it. So that's good.
Yeah. So, but I always have a question about the depth of sedation. I often think that for a young kid, and you also said that for a kid younger than 6, any sedation is deep sedation because they won't allow anything to happen, even a non-invasive, non-painful, and brief procedure. So, but in our city, or I think in many part of the world, they always think, oh, it's only a chloral hydrate or only desmedetomidine, so it's only minimal sedation, and they don't need monitoring. What would be your comment on this?
Well, two things. With chloral hydrate, it's actually quite a safe, quite a safe medication, but there have been deaths reported with chloral hydrate. In that paper that I cited, that review, there were 13 children that died having received chloral hydrate. And the problem is that we're not perfect and we make errors. So if we mix up the concentration, like I think one of the cases I described was where they gave